I'm Renu Virmani, and I'm going to talk on a pathologist perspective on drug-eluting stents and drug-coated balloons in the treatment of femoral popliteal disease. Is the danger real? These are my disclosures. I have nothing important to disclose. So, Paclitaxel is indeed effective in preventing restenosis. It's a cytotoxic drug used for chemotherapy. It has a narrow therapeutic window and very effective in inhibiting smooth muscle cells proliferation and migration. Paclitaxel, we know, binds to beta tubulin and impairs microtubular disassembly and halts the cell cycle between the G2 and M phases. We also know paclitaxel has an ability to kill rapidly multiplying cells and therefore is used as a chemotherapeutic agent for a lot of cancers. So what are its toxicities? Its toxicity that we know very well, a hematological toxicity, that is leukopenia, neutropenia, generally observed at the doses of 175 milligram per meter square or greater. There are neurological toxicity at higher doses, and nausea and vomiting, alopecia, other common side effects. The high doses we have reported increases in the external elastic lamina area, and I'm going to get into that a little later and not really talk very much, but we certainly know that paclitaxel has been used on stents in the coronary arteries, specifically in the taxa stent, and it did have unfavorable results. It resulted in positive remodeling, and there was also a slight increase in thrombosis overall. So should silver PTX be used instead of bare metal stents in failed DCBs? Is this strategy really safe? So here I'm concentrating mostly on stents, and I think as well as DCB, because it's easier to understand DCB effects if we use a bare metal stent as compared to a drug-eluting stent. So what we did is we looked at DCB in the presence of bare metal stent, we looked at DCB in the presence of silver PTX, and we did a plain old balloon angioplasty in the presence of silver PTX. These were implanted in porcine superficial femoral arteries, and the animals were sacrificed at 1 month, and the biological effects were compared. So here is left and right SFA were randomly assigned to DCB bare metal stent, DCB silver, plain old balloon silver. And as you can see, we alternated, and that's what I will present the data to you. So what are we going to look at? We histologically examined to look for specific markers. We wanted to look at endothelial cells. We wanted to look at interstitial smooth muscle cell density, fibrin deposition, medial smooth muscle cell depth and loss, looking at their depth as well as in circumference. And we also wanted to understand whether medial proteoglycan collagen replacement, how much had occurred. So this is the data showing green represents DCB with bare metal stent, red is DCB with silver PTX, and blue is plain old balloon with silver PTX. First row top shows struts with greater than 50% fibrin. As you can see, DCB with or without plain old balloon, but silver PTX was present, showed much more fibrin as compared to if you did DCB alone with bare metal stent. That's true for neofibrin, neointimal fibrin. Now it is also seen that interstrut smooth muscle cell density was lowest when we use silver PTX with plain old balloon or with DCB. Medial proteoglycans was also, and collagen was increased in case of DCB silver PTX or plain old balloon silver PTX. Medial smooth muscle cell loss was maximum in the presence of silver PTX with DCB or just using plain old balloon. And medial smooth muscle cell circumferentially was also greater when we had silver PTX present. Now, looking at the analysis in terms of proteoglycan, you can see we had much greater proteoglycan. Here we also included just DCB without any stent. And as you can see, proteoglycan, its effects are much greater in Zilver PTX with a DCB or just Zilver PTX and a plain old balloon. Smooth muscle cell similarly is greatest in those with Zilver PTX. Similarly, smooth muscle cell loss in circumference is also greatest in presence of Zilver PTX, showing that DCB as such is not as effective as stents covered with Paclitaxel. So here are the images showing DCB BMS. You can see that we don't see any red at all as shown here. You can see that's fibrin. Very clearly, we see maximum fibrin in DCB Zilver PTX, although Zilver PTX shows similar amount. As you can see, fibrin is noted in Zilver PTX with DCB or with plain old balloon, but not so much with DCB with bare metal stents, although it's present, but it's not as marked. So we also were interested in looking at downstream skeletal muscle in the swine model. This just shows you the various leg muscles, as all of you know, and I'm not going to go into greater details. It's just these were looked at. So what we found was, when did we see the most distal emboli? We saw distal emboli essentially when DCB was used. That is, with bare metal stent or with Zilver PTX. Zilver PTX with plain old balloon did not show us any distal vascular changes or any emboli. As you can see on the right, shows fibrinoid necrosis, and you can see thrombus on this side on the right. So on the whole, DCB is more responsible for distal emboli than stents. Stents do not cause distal emboli. So in conclusion, irrespective of DCB or plain old balloon, Zilver PTX showed maximum biological changes in the neointima and media suggestive of superior drug effect with Zilver PTX. Distal vascular changes were exclusively seen in groups with DCB and not with Zilver PTX. Now I'm going to show you data on looking at the FDA-approved drug-eluting stent, that is Zilver PTX, comparing it to Eluvia. You can see Eluvia has abdominal delivery of the drug. Zilver PTX has abdominal delivery of the drug, whereas Eluvia has circumferential delivery of the drug because it has a polymer, and the amount of drug that is needed in Zilver PTX is much higher as compared to needed in the Eluvia. So you can see the loading is much lower in Eluvia stent. So what about the release kinetics? As you can see, in the green shows the Zilver PTX, whereas in the yellow, it shows the Eluvia. You can see it's much higher drug in the first 28 or up to 56 days, much higher in Zilver PTX as compared to Eluvia. But Eluvia continues to release the drug even up to 360 days. So you can see that it is the Eluvia releases the drug for a long time, Zilver PTX for 56 days. So we compared the two at 1 month, 3 months, 6 months, and 12 months in a porcine femoral artery model, as I've already shown you, and then we sacrificed the animals at these different time points. So looking at the stent area, you can see the stent area is slightly larger in the case of Eluvia as compared to Zilver PTX. It is much less stent area. Lumen area is bigger in case of Eluvia as compared to Zilver PTX. Percent stenosis is similar, except the difference is seen more at 3 months. It is much greater. The percent stenosis is greater in Zilver PTX than Eluvia. Smooth muscle cell loss is also greater in depth. Neointimal fibrin score is also greater in the case of Eluvia, and endothelial loss is much greater at 1 month in Eluvia as compared to Zilver PTX. And after that, there are no differences. Now, this is to show you 1 month, 3 months, 6 months, and 12 months, what Zilver PTX looks like versus what alluvia looks like. You can see we see a lot of fibrin in case of alluvia in the peristrut region, as you can see here, and you can see even up to 6 months, but not at 12 months. We do not see much of fibrin at 12 months. Now, looking at overall, again, at 1 month, 3 months, 6 months, and 12 months, stent area, you can see is bigger in case of alluvia as compared to Zilver PTX, which is shown in green. Medial injury is also greater in alluvia as compared to Zilver PTX. Inflammation is greater all throughout from 1 month all the way to 12 months. And the giant cell are also greater around the struts in case of alluvia as compared to Zilver PTX. So what about the effects in patients? So if you look at patients, they showed at 1 year that alluvia was more effective in the proportion of patients with primary patency. You can see 88% in alluvia versus Zilver PTX 79%. And that is also true in TLR. It is greater in alluvia. The TLR rate without the proportion of patients without TLR is much greater in alluvia as compared to Zilver PTX, but the difference is fairly small. But what is interesting at 2 years, both the patency as well as target lesion revascularization are no longer different. You can see alluvia is 83%, Zilver PTX 77%, and these are no longer different, significantly different. So our results with the animals as well as human seem to parallel, although the timing is somewhat different, that at 1 year in animals, we don't see an effect, whereas in humans, 2 years, we don't see a difference in the effects. So here is a paper which came out from Germany looking at the alluvia, which was implanted in 62 patients in their complex femoropopliteal artery patients with CTO in 79%, moderate severe calcification 42%. What they showed was there was aneurysmatic degeneration at 12 months in 5 patients. That is, 8% of patients had aneurysm formation. Now they did the same thing with their trial in which they compared the imperial randomized control trial. They also showed that overall 6 cases showed aneurysm formation at 1 year duplex ultrasound imaging. 6 cases, all were in the alluvia group and none in the Zilver PTX. So showing similar results as the German group. So now in summary, we can say our preclinical study shows stent expansion and obtained lumen area are significantly greater in alluvia as compared to PTX, Zilver PTX. Percent stenosis was greater in Zilver PTX versus alluvia only at 3 months. However, there were no remarkable difference at 6 months and 12 months, which parallel those of human. If you look at PTS effects upon vascular wall, was significantly greater in alluvia at all time points. Entire circumferential medial layer disruption was observed only in alluvia in 3 cases at 6 months and 12 months, with normal healing course at contralateral Zilver PTX treated vessels. The distinct characteristics of Zilver PTX and alluvia regarding chronic outward force and drug release profile allows us to understand the results of clinical trials, which show greater patency at 1 year in alluvia as compared to Zilver PTX and aneurysm formation, but no differences later on at 6 months and 12 months in animal, and no difference in human at 2 years. So now let's talk about what are the problems with Paclitaxel, which was pointed out by Cansano in 2018. He showed that in a random effects of forest plot, all-cause mortality at 2 years was greater in drug-eluting stent as compared to control, favored control. Now, if you look at random forest plot effects of all-cause death at 4 to 5 years, was also favored the control group as compared to Paclitaxel. But if you look at the causes of death, there were no real patterns seen. in terms of cardiovascular, majority were cardiovascular, infectious was 5, cancer in 2, pulmonary 3, and others 3. And in control, there were very few. Now, most patients don't die of their peripheral vascular disease. Most of them die from other complications of cardiovascular. So let's look at why paclitaxel could not be responsible for this. We know it is effective in preventing restenosis, but has a limited therapeutic window. I have shown you this before. This is just a repeat of that slide saying the hematologic toxicity is the most important we should be looking for. So if you look at chemotherapeutic doses at a comparator, doses for chemotherapy vary from 80 to 200 milligram per millimeter square. Average body surface area is in men is 1.9 and women 1.6. So the total dose per treatment varies from 128 milligram to 380 milligram per dose. The average dose of paclitaxel in IMPACT SFA PK sub-study was 7.454 milligrams with an average subject weight of 91 kilograms, assuming the paclitaxel coated enters the systemic circulation. So where do we see toxicity in patients who are receiving paclitaxel for chemotherapy? 175 milligram, which is much higher. And also it starts at 175, not before that. Hematological complication were not seen, only at 175, which is a very high dose. And very rarely did we see other like nausea, vomiting, neurotoxicity was not seen. And yes, alopecia side effects of vomiting, nausea were seen. But what is most important is look at the dose that we get with impact. If we were to use a balloon 5 millimeter by 120 millimeters, dose of a patient with 2 such balloon would be 14 in case of impact. In the case of Lutonix balloon 2 would be only 7.6 milligram, which is far lower than what is given in one dose in chemotherapy. So if you look at in the Levant trial, when does paclitaxel disappear in the circulation? Within 30 minutes, paclitaxel is almost totally gone. What about in porcine organs? Do we see the presence of the drug? Yes, we see presence of drug in the lung, we see presence of drug in the liver, and we see presence of drug in the kidney. Highest doses up to 30 days, it becomes almost negligible and remains in the lung is seen up to 90 to 120 days. And after that, not seen, although liver and kidney small doses are present up to 120 days. What about the total chemotherapeutic dose, maximum dose that we see with chemotherapy and the area under the curve? You can see that in the kidney, it's much higher, 34 to 340, liver 80 to 525. And if you look at lung, 34 to 354. What about in the case of femoral pharmacokinetics? We see much lower in the case of the pharmacology in the animal studies where the maximum dose is given, and you can see it is significantly less. It is not anywhere near what is given in humans. And what is interesting in humans to see is that in breast cancer patients who were treated with paclitaxel, and you can see over the years that 4-year survival was much better in paclitaxel as compared to when they were compared with cyclophosphamide or cisplatin given in those cases. Cisplatin was also given in paclitaxel. But look at the survival at 4 years, and all throughout is much better in the presence of paclitaxel as compared to cyclophosphamide, suggesting that there should be no toxicity whatsoever in patients who are getting these balloons. So in summary, the findings that I have shown you are DCB drug delivery is inefficient because most of the paclitaxel does not make it to the target site and is lost in the body. Overall total dose of DCB to the patient is much lower than required to cause paclitaxel toxicity, as reported in oncology data. PK data suggests plasma levels of 58 nanogram per milliliter systemic dose with 290 micrograms within minutes following treatment and declines rapidly thereafter, becoming undetected after 30 hours, and never achieving levels sufficient to cause toxic effects such as neutropenia. The use of crystalline paclitaxel enhances tissue drug residence and provides a drug reservoir, as drug does not solubilize easily. Nevertheless, it is hard to imagine how the relative single dose paclitaxel on DCB could cause adverse effects, making it responsible for the increased mortality. We must look for other causes, that is, underlying disease, cardiovascular specifically, and other factors which may account for the findings in the meta-analysis. It could be bias, it could be all kinds of other things. So I'd like to thank you for this opportunity to speak to you. Thank you.